Hello, we are back. Lisa Wessel with Encompass Women's Health, and I'm Diane. Be sure to like and subscribe to the YouTube channel. We're going to talk about progesterone, what it is, why is it important, why do we need it, all the deets.
Progesterone is kind of like don't take this personally, any redheaded stepchild, but like that's the verbiage. It doesn't get a lot of love. Like, no, progesterone isn't the same as estrogen. They're not the same. Progesterone is an important hormone. When we talk about hormone therapy or talking about hormones with women, those are the three: estrogen, progesterone, testosterone. And progesterone, what everyone knows it for is that if you're using estrogen therapy and you have a uterus, you have to take progesterone. And that is true because progesterone keeps the endometrial lining thin. Estrogen will cause your endometrial lining to grow, and progesterone is the lawnmower. And it's like, nope, okay, it's time to mow the lawn. We're going to keep this nice and thin. That's its job. And if we are just giving estrogen, then we're allowing that endometrium to grow. And when we are talking about an area where there's a lot of cell division over and over and over again, there's a lot of room for error to happen. And so this is where, if we're just using estrogen and not progesterone, we are putting women at risk for endometrial hyperplasia or cancer is the easy, like uterine cancer essentially is what it is. But it's stemming from like the endometrium, which is the part that we slough off every month. That is one of the reasons we use progesterone. And I would say, like, very conventional thinking is, well, if you don't have a uterus, you don't need progesterone. And the reality of that is that's not true. We know from the WHI study that we want to avoid the synthetic version because the synthetic version of progesterone was where there was a small increased risk of breast cancer. And so it was the combination of the estrogen and progesterone, but the synthetic version. And so if we're going to use progesterone, we want to use the body identical version of progesterone, which is going to be micronized progesterone, or prometrium is the other name. Provera is the synthetic version. And so Provera, I would say, like, that's typically the one we want to avoid, which interestingly enough is almost always covered by insurance, but that's not the one you want to use. You really want to go with the micronized progesterone. The other thing that progesterone does for women is it turns on the GABA receptor in our brain. And so GABA is our inhibitory neurotransmitter, and progesterone tells the brain, like, we're done, dude. It's like the day is over. It's time to go to bed. I always feel like it's that friend that goes zip, 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 zip. Like, it's just like, no, I'm not doing this with you. This is like not a discussion. We're going to sleep. And so that's what's nice about it for women. And if anyone has tried progesterone or is on progesterone, we take it at night because it puts us to sleep and keeps us asleep typically. They do make progesterone, so the micronized body identical progesterone that's FDA approved is 100 milligrams and 200 milligrams. So there's something in the progesterone that little pieces come out essentially throughout the night. And some people can't tolerate that. And so we have to change and make something compounded. Essentially, that's why we use progesterone. It's a natural diuretic. It is a natural Xanax to our body. And I think the biggest thing is people sleep. And if women are sleeping, they are feeling better. You can fix a lot with just sleep. So 100 milligrams, a lot of times the starting point, but going up to 200 is appropriate. I have some people on 400 for different reasons. I would say, like, one of the negative side effects of progesterone usually is like pants. For some, they will get really a lot of gastrointestinal diarrhea problems. Some people don't tolerate progesterone. Some people get really bloated on progesterone. And so we have to find different ways to give it. The oral form is where we get the GABA to turn on. That's where we get the best, the sleep part helps with it. And sometimes it is figuring out what is the best dosing for this person. If someone if they have a uterus and they are using estrogen, we need to do both. Now, the also caveat on that is, if you are in perimenopause and you are still having periods, your body is still producing progesterone, probably not as much as your body needs or is used to, but the risk of endometrial hyperplasia is very low. And so you could be on estrogen without the progesterone piece in that phase. But once we've gone that full year without a period, it's a really good idea to have that on board. And, I think the thing is like, we don't necessarily know when that last menstrual period is going to happen. And so utilizing your progesterone prior to that can be extremely beneficial. Most people are sleeping better, so they like it.
Oh, absolutely. So then what are the benefits of taking progesterone and magnesium at night? What does magnesium do?
No, there's a lot of different forms of magnesium. And if we're talking about magnesium, we're talking typically the main ones if you're talking about glycinate or citrate. Citrate is usually more to help with bowel movements. You will get some effect with sleep, but you're going to have to be shitting your pants as well too. No, not always, but a lot of gastrointestinal. But the neurotransmitters, it helps. It's calming. It helps with that as well too. A lot of people like taking magnesium at night can help. Magnesium helps with brain functionality. It also helps regulate out our blood sugar. It plays a lot of roles. It's an electrolyte balancer. It plays a role in the heart. Usually taking a magnesium at night, a lot of women find that to be beneficial and helpful for sleep.
Can you take too much magnesium?
You can, and usually your body, regardless of the type, if you're taking too much, you'll start having diarrhea. Your body will like, yeah, this is too much. So if you're noticing that, that would be a sign that, hey, this is too much for my body. So it does try to level itself out a little bit. I would say 500 to 1,000 as kind of the range. And a lot of people are taking less than that, but neurocognitive kind of things at night, usually you're talking about 500 milligrams. Thing is, it's a certain piece, and usually can make a big difference. If I was on a job interview and I was progesterone, I would tell you my job is I help with sleep. I turn the brain off. I'm a natural Xanax. I'm a natural diuretic. I protect the uterus. But like I'm going to help neurocognitively, like going to bed, feeling well rested. That's my job.
When you do blood work and labs, can you identify, is progesterone one of the levels that you track? How do you know if someone needs it?
Everyone does labs a little differently. I typically do lab work if women are having periods on the second half of their cycle, so after ovulation. So you're looking at that estrogen progesterone ratio. Is estrogen where's estrogen? Is progesterone coming up because it should be rising on the second half? Is it not? It's taking its time. Is estrogen hanging out too long? Most of the time, progesterone's low. It's only like that's where its glory is on the second half of the cycle. The rest of the time, it's fairly low. When we're doing therapy, you are looking at it. You're looking at kind of like estrogen to progesterone a lot of the times. Postmenopausal, like, wow, your estrogen's really high. Progesterone seems to be like kind of on the lower end. Are we having any problems? Like usually like people are feeling fine. They're not having any issues.
You mentioned something earlier that I just kind of want to go back to, and waiting for the 1 year of our period to end and be done can still treat the symptoms,
Yeah,
even if you
absolutely.
haven't had that 1 year. Like, I think that's another myth almost that,
Yeah.
yes, it's official, you're through menopause, but it doesn't mean that you have to wait that long to start treating it.
Yeah, 100%. So that's the thing about perimenopause and the challenging piece. The definition is 12 consecutive months of no period, but that doesn't mean we don't need help prior to that. Anytime women start to notice prior to that, like even women start to notice changes even before there's a change in their cycle. The cycle is a tangible thing we can touch. You know what I mean? I'm losing my mind. I can't remember things. I mean, we're talking about it a lot more, which is great. Like I'm sadder. I'm not able to cope as well. Like those are all very subjective things, but like objectively, I can tell you I haven't had a period in 98 days. My little app. I can tell you that. I can tell you prior to that, my periods were really close together. Like they're doing whatever the hell they want. So right now, 98 days, that means I don't have any estrogen. That means I'm not like having fluctuations, or I probably am, but they're just not high enough. Like it's kind of the movie Castaway when he's trying to get out, right? And he can't get over that first wave, like, and then gets pushed back. Hormones got to get high enough in order to like, okay, now we can do this whole thing. But they're just not consistent enough. So perimenopause is time for treatment. And lab work doesn't always show us what we want. So there is that concept of both. Like I've got labs and how are you feeling? And I don't know where your body liked to be. I have a general idea. Lab work doesn't mean anything unless I'm talking to someone. So if you
Right.
throw labs in front of me and I don't know anything about the person, I can give you this is what it looks like. But my next question will be, what's going on with the patient? Like, what are they saying? What are their complaints? When was their last period? Oh, they don't know. They had an ablation. They have an IUD. They have, like, okay, well, so we have no idea like where we are on this 12-month window. This is what the labs are showing me, but this is what they're saying. I think if let's put those together and this is where I would start. And I think when we're talking hormones specifically, it doesn't mean I'm right. It doesn't mean anyone's right. It means
Mhm.
this is giving me a good data point of maybe where to start, and we need to circle back. Let's see how this goes. How are you feeling? What's the good part of this therapy? What's the bad part of this therapy? And now maybe we need to add something in or take something out. So
Mhm.
it's a process.
If you like to follow recipes, this is a real bumpy time to begin with, and then it's because we're talking about dashes and pinches and not cups. If a woman goes to her provider and says all these things, I am getting periods, they're irregular, but I feel tired, I feel all these different symptoms, and the provider's like, I'm not going to prescribe anything else. You still having periods. What is your suggestion to them? We treat symptoms. And then there's the emotional part like, oh man, I've just been shamed and I'm crazy. This hysteria, you're just being a woman. There's still that narrative that's very pervasive, even though we're talking about it. What advice would you offer? Would you suggest?
Find another provider. I mean, that's number one. I think it's being able to have a discussion with your provider about why you would like to try something. And almost always it comes down to comfort level, not because they don't want to prescribe that to you. It's they're not comfortable prescribing it. And or they don't know enough in order to do that, or they don't feel comfortable managing that. And so, a provider that says that is worth their weight in gold. You know what, that's really out of my wheelhouse and I'm not comfortable with that. I would rather you see someone who specializes in that. That would be like, that's someone who, like, you can't not respect that. I think that's the thing as a provider. There's a little bit of shame or fear that maybe, like, what I mean? I don't want to tell someone that I can't do something, but there's an extent for all of us. There's a certain comfort level. I feel comfortable with all of this, but this is now turning into something that someone else needs to manage. So if you're having that issue, that's where it'd be like, okay, well, thank you.
Just because someone's an OBGYN doesn't mean that they have the specialty and the training like you do for perimenopause and menopause. It's a specific certification that you get and studying in CEs, continuing education hours, and that you work towards so you are up to date, correct?
Yes. And I always tell people medicine is like, it's a general concept. You learn on the job, just like every other job. You learn, you fail, you succeed. Um, that's how it works. And so we've all done things that didn't work. We all have a story. We all learn on the job. We are given a basic until you start doing it. There are people are experts in bacterial vaginosis. There
Mm-hmm.
are people that are experts in vestibular vulvodynia, which is specific. This is very, very specific. And that's all they do. And there are
Mm.
enough people out there that need those people. Even as a women's health nurse practitioner, to be able to say, yes, I have this knowledge base and I can do this and this. And if we've done this, we've done that, like we tried this, like, hey, you know what? We're not getting anywhere. Maybe we need to now seek someone specific. And so it can be the same with your hormones.
I think it speaks to, as a society, trust that doctors and nurses are infallible, that you have all the answers and you know everything, forgetting that you're human.
Unfortunately, we learn by well, both. You learn by your successes, but you really learn by those failures.
Thank you for educating us on the redheaded stepchild of hormones. We love you, progesterone. We need you. We see you.